My name is Mike Corvino, and I'm a pharmacist based out of Charleston, South Carolina. In this video today, we'll discuss a class of medications used in patients with type 2 diabetes called GLP-1 receptor agonists. There are 5 currently on the market, and there's also 2 more that will probably be approved in the next year or so. So I want to discuss how these medications work, as well as review some of their efficacy data. It is really important to be able to differentiate between the drugs in this class so that we are able to make appropriate recommendations for patients in a clinical setting. And the great thing about this particular class of medication is that we have plenty of head-to-head data available to us. Before we get started, I want to pose a question. So in regards to glucose, which route of administration is going to elicit a higher insulin response? Is it oral intake or intravenous? The answer is actually oral glucose intake, and this is referred to as the incretin effect. The incretin effect is a result of certain peptides that are released from the gastrointestinal tract after glucose is consumed. One of those peptides is GLP-1. GLP-1 receptors are located throughout the body, and they're responsible for various functions. So when GLP-1 binds in the pancreas, beta cells are activated to increase insulin release. The insulin will allow for an uptake of glucose into the cells, and then the enzyme hexokinase will also be activated, which will phosphorylate that glucose and trap it inside the cell so that it can be used for the production of ATP or to be converted into glycogen for storage. Pancreatic alpha cells are also affected by GLP-1 binding. This is going to cause an inhibition of glucagon release. That lack of glucagon will halt the breakdown of glycogen stores in the liver, as well as block the process of gluconeogenesis. And many patients will also experience weight loss with these medications. This is because of 2 main reasons. The first is GLP-1 binding in the stomach actually slows gastric emptying. And the second reason for weight loss is the GLP-1 receptors are located in the hypothalamus, which is going to play a role in appetite. So patients will often describe increases in satiety after a meal. Natural GLP-1 has a short half-life and is then broken down by an enzyme called dipeptidyl peptidase 4. GLP-1 receptor agonists were designed to resist the effects of DPP-4. Now we also have a class of medications called DPP-4 inhibitors, and the DPP-4 inhibitors currently available are Januvia, Onglyza, Tradjenta, and Nesina. I bring these up because you may come across patients who are taking both a GLP-1 and a DPP-4 inhibitor. Because these medications work on the same pathway, it is unnecessary for someone to be on both medications at the same time. There is not a significant benefit with the combo, and it typically increases the patient's side effect profile. Byetta, exenatide, was the first GLP-1 on the market. It is dosed twice daily and injected using a pen device. The patient will need pen needles just as they would with an insulin pen. The doses are injected within an hour of the morning and evening meal. Now keep in mind, Byetta dosing has renal limitations, and it's actually contraindicated if a patient's creatinine clearance is less than 30. Victoza, liraglutide, is a once-daily GLP-1 made by Novo Nordisk. It also requires separate purchase of pen needles in order to use the delivery device. The safety and efficacy of Victoza was examined in the LEAD trials. LEAD 6 compared Victoza head-to-head with Byetta. Victoza had a reduction in A1C of 1.12%, and Byetta had a reduction of 0.79%. This difference was statistically significant. Patients in the Victoza group had a weight loss of 3.24 kilograms, which is about 0.4 kilograms more than patients in the Byetta group. Both drugs had similar adverse effects, with less nausea and hypoglycemia in the Victoza group. Victoza also has data that shows cardiovascular benefits. The LEADER trial included 9,340 patients with type 2 diabetes. The patients that they included in the study were 50 years of age or older and had at least one coexisting cardiovascular condition, which could include coronary heart disease, peripheral vascular disease, chronic kidney disease stage 3, or heart failure classes 2 and 3. They also included patients who were at least 60 years old with at least one cardiovascular risk factor. The primary composite outcome in the time to event analysis was the first occurrence of either death from cardiovascular causes, non-fatal MI, or non-fatal stroke. Victoza showed a significant reduction in the primary outcome with the number needed to treat of 55. All-cause mortality and all-cause MI were also reduced, with numbers needed to treat of 72 and 94. There was no difference seen in the occurrence of stroke between the two groups. Let's move on to Bydureon, which is the extended-release form of exenatide. It is dosed once weekly. This pen was designed to be a one-time use and needs to be reconstituted before it can be administered. Some patients find the reconstitution process difficult, so it's important to show patients how to prepare the pen when they are first starting Bydureon. The duration trials were used to examine the safety and efficacy of Bydureon. The Duration 6 trial compared Bydureon head-to-head with Victoza. In order for the A1C lowering benefits of Bydureon to be considered non-inferior to Victoza, the upper limit of the 95% confidence interval had to be less than 0.25. Bydureon lowered A1C by 1.28%, while Victoza lowered A1C by 1.48%. The difference between the treatment groups was 0.21%, with a 95% confidence interval of 0.08 to 0.33. So because the upper limit was higher than 0.25, Bydureon did not meet the pre-specified criteria for non-inferiority. In regards to side effects, Bydureon had less GI upset, but showed more injection site reactions. Tansium is another once-weekly GLP-1. Just like Bydureon, Tansium is not considered to be user-friendly because of the somewhat difficult process to reconstitute the pen. The Harmony trials were conducted to establish its safety and efficacy. Harmony 7 compared Tansium directly to Victoza. In order for the A1C lowering effects of Tansium to be considered non-inferior to Victoza, the upper limit of the 95% confidence interval had to be less than 0.3. Tansium lowered A1C by 0.78%, and Victoza lowered A1C by 0.99%. The difference between the treatment groups was 0.21%, with a 95% confidence interval of 0.08 to 0.34. Because the upper limit was higher than 0.3, Tansium did not meet non-inferiority. In regards to side effects, Tansium had less GI upset, but more injection site reactions. Trulicity is the other once-weekly GLP-1. This pen is actually designed very well. The patient simply removes the gray cap at the end of the device, turns the other end to the unlocked position, and the dose is ready to be injected. The needle retracts so the patient never has to see it. Trulicity was compared to Victoza in the Award 6 trial. Trulicity showed A1C lowering by 1.42%, and Victoza lowered A1C by 1.36%. The 0.06% difference met the criteria for non-inferiority, but not superiority. Also, Trulicity did not meet non-inferiority to Victoza for weight loss. The GLP-1 receptor agonists under investigation include Sanofi's lixisenatide and Novo Nordisk's once-weekly GLP-1 called semaglutide. The SUSTAIN trials are looking at safety and efficacy of semaglutide, and like Victoza, semaglutide is also being examined for potential cardiovascular benefits. GLP-1s will also be available in combination with insulin. Victoza will be combined with insulin degludec or Tresiba, and lixisenatide will be combined with insulin glargine. Let's quickly look at side effects. So nausea, vomiting, and diarrhea are very common when someone is first starting a GLP-1. The GI upset typically subsides after a few weeks of use. Injection site reactions are also possible. Patients should be advised to rotate injection sites just as they would with insulin. One of the more serious concerns is pancreatitis. This comes from post-marketing reports that showed a possible risk for acute pancreatitis in patients using GLP-1s. Several retrospective cohort studies and meta-analyses have not been able to identify a definitive risk for pancreatitis. GLP-1s are probably best avoided in patients with a history of pancreatitis or with risk factors such as triglycerides over 1,000 or chronic alcoholism. GLP-1s also carry a black box warning for risk of thyroid C-cell tumors. These tumors were discovered in rats that had been exposed to GLP-1s consistently over their lifetime. Because of this, GLP-1s are contraindicated in patients with a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia too. So just to recap, Victoza is considered by many to be the gold standard for GLP-1s. If a patient does not want a daily injection, Trulicity would be an appropriate substitution. And my personal view, simply based on the current data, is that at this point, Byetta, Bydureon, and Tanzium have a very limited role in clinical therapy. Thank you for taking the time to watch this video, and please let me know if you have any questions. I would also love to hear your comments, so feel free to leave feedback. Thanks.